I'm Heidi Bragg, and this is Life, Cancer, Etc. My goal with this podcast is to connect you with stories and resources that help you feel happier, more resilient, and less stressed, especially when you're going through hard times. Okay, today I'm talking with Dr. Andrew Brohl. Dr. Brohl is a clinician and a researcher at Moffitt Cancer Center in Tampa, and one of his specialties is sarcoma, which is the kind of tumor I had in my heart. Good morning.
Good morning. Nice to see you.
You too. You without a mask, too. It was interesting. I thought, what's weird? Oh, I can see his face.
I didn't realize we'd be on a video chat. I would have shaved for you. I don't know. Sorry.
No, video doesn't show up. I only post the audio.
Good.
Okay, so tell us a little bit about what you do at Moffitt.
Sure. So I'm a medical oncologist. So I help deal with things like chemotherapy and other systemic therapies. And also a physician researcher. So I spend part of my time seeing patients in the clinic and giving them advice about their treatments, and spend part of my time in the laboratory trying to do some experiments and learn more about these cancers. And I'm a rare cancer specialist, I would call myself. So I mostly take care of people who have various types of sarcomas, which is obviously what you had, and also take care of people who have another cancer called Merkel cell carcinoma, which is a rare skin cancer, and kind of help lead up the efforts on that at Moffitt as well. So that's kind of what I do.
That's enough, I think.
What? Say again? Sorry.
Oh, I just said I think that's enough. I think that's a pretty good amount of stuff to do in a day, don't you?
Yeah, well, it's good. It's part of the reason I like this job and what I do is the variety from it, and part of the reason I even went into this in the first place was to be able to have that balance and that variety to do the research as well as take care of people.
Okay, we're having a little bit of audio problems, but we're going to work through it. So tell me a little bit about why you got into this, because this is a very specialized field. So what drove that for you?
Well, I guess it depends on what part of the process, you're talking about. There's a few different steps along the way before you kind of get into like sarcoma and research and even doctoring in the first place. But, with, I guess, growing up, I didn't necessarily know I wanted to be a doctor. Even I just was good at math and science and thought I would do something science related. And, was even when I was late in college, wasn't really sure that I was going to be a doctor. Was kind of vacillating between that and like PhD school and be more or less a scientist. And when I was looking at sort of like science things, I was even thinking more like along the lines of maybe like a physicist, something like that's kind of way out there and not different from taking care of patients. But ultimately, I kind of got drawn into the idea of doing something that's a little bit more tangible and maybe more relevant. I thought could get a little bit more like esoteric if I went the other way, and also had a little bit more of a clear career path going that way. It was kind of like easier to see what I would actually do moving forward. And I guess even if the research part didn't fully work out, you'd still have this great opportunity, great career taking care of people and being a doctor, and could do clinical research. And so it seemed a little bit more flexible there, and kind of worked out for me that I'm still able to do the science part of it to a great degree, like I like to. So that's kind of what drew me into medicine in the first place. And then, for sarcoma more specifically, I kind of got into it mostly through the research side. Basically had a mentor during my training that was researching sarcoma, and then, I got into that through that. And, once I started doing it a little bit more, I sort of appreciated the need for it in a rare cancer. There's always this, problem that, rare cancers are kind of difficult to research and difficult to take care of and more people are needed to do it, even though, you would think you need to put more emphasis on the more common things. It's underrepresented in research. It's underrepresented in, sort of specialists in it. And so I think there's a real need for it. And there's also a sort of a scientific interest part of it too. Where there's, a lot of examples in cancer research and cancer medicine where we learn a great deal by studying the rare things. There's A great example is a cancer called retinoblastoma. It's a cancer that children get, or young children get in their eye, and it was one of the first cancers that was discovered to be heritable, and the gene that was kind of discovered out of it, which is now called the retinoblastoma gene, is pretty commonly affected in a lot of other common cancers too. If you look at all cancers everywhere, breast cancers, lung cancer, sarcomas, about 10% of cancers have a defect in this gene also. And so we kind of learned a lot about the genetics of cancer through this rare childhood tumor being studied. And so there's a number of examples like that. And, my whole shtick or spiel when I'm trying to, ask the government for money to fund my research is that, if I study this super rare thing that nobody is looking at, maybe I'll learn something like that too, that doesn't just affect a few people, but kind of is, some sort of breakthrough or, insight to other things.
A lot more universal than maybe they would expect.
Yeah. So I think that's sort of what I like about it. And so it's like this need thing. So you really, it's people are coming and, it's hard to find researchers for some types of sarcomas, even if you're, for people who are diagnosed with this and looking for like an expert. I've, come across some that it's really even hard to find like the go-to person in the world for it, for some of these, ultra rare ones. And so it really, I think, is kind of a need as well. And
yeah, amen to that.
It's been a good, fit for me, I guess, and rewarding, to do that.
Well, and okay, so I'll describe a little bit about the first time you and I met, and then I'd like to hear about that encounter from your perspective. So
sure.
We had met with my regular oncologist, who kindly but pretty clearly stated that, so we'd come in, I'd had open heart surgery. They figured out that the tumor was not a benign myxoma like they thought it was, that it was this sarcoma. And did we ever figure out if it was undifferentiated or angiosarcoma? Do we know?
I think we're calling it undifferentiated sarcoma at this point. It's been called both by the pathologists in different time points. And, and the angiosarcoma is, one of the ones that can affect the heart. It's a tumor that comes from the lining of the blood vessels or the heart itself. And so location wise would make sense. But, I think it ultimately lacks some of the markers that we would tend to find on angiosarcoma. So it's been, I think, probably more appropriately classified as just an undifferentiated sarcoma, which is somewhat of a catch-all term. It's one we don't find any of the more specific markers to lead you down to a different sarcoma type, and it lacks like the markers for angiosarcoma or liposarcoma or LAMA or these other things. But it turns out that a lot of sarcomas are fit into that category. So it's actually one of the bigger categories of sarcoma that we end up classifying things as. But ultimately, that's what yours is.
Okay, so I walk in there, and my other oncologist has said, this is basically, odds are this. I'm like, is this something we can treat? Or she's like, you can probably buy some time, but sarcomas are very aggressive, and they usually come back, as you told me, within usually 6 to 8 months. So Kev and I walk in, and we're talking with the resident, Dr. Risk. And she's talking to us about this. And then you walk in the room and you give us basically the same outline, but you're like, but there's this little window. Like there's this little window. If you can hit it, it works, but you have to be really aggressive, and the odds are not great. So just know that going in. And I'm like, what are the odds? And Kev always laughs at me because he's like, he gave you a number because you kept pushing him to give you a number. I'm like, what are the odds? And he's like, 5%. Well, first you hemmed and hawed for quite a while because you're like, I'm not giving you odds. And they're like, fine, 5%.
Yeah. I remember you really pushed me on that one. We hate giving people numbers because we're it's so, I don't know. It's a tough balance. You want to, not be giving somebody false expectations or, unrealistic expectations, but also not like kind of completely crush them and, crush all hope. And, especially in the medical oncology field. So, we're the people who deal with chemotherapy and, in some cases now immunotherapies, which is a, kind of an emerging thing for cancer treatment for some types. And so, you're typically giving those types of things to people who have either, the bad ones, the ones that are already at an advanced stage, or ones that are really high risk to come back. So, we're not really seeing patients that have like the easy cancers that a surgeon takes out and it's kind of like end of story. we're typically in my field see people who have a tougher one that may need chemotherapy or something like that. And so, a big part of our initial meetings with anybody when I first meet somebody is really sort of expectation management, and and trying to balance hope without giving false hope,
Yeah.
and that's sort of the needle that I'm trying to thread frequently. Often it's in your case, I think you were actually pretty well prepared for our conversation, and thankfully, the previous oncologist who spoke with you was, fairly upfront with you. But, oftentimes it's actually the most difficult part is getting that initial.
Hang on, your audio cut out. So you said oftentimes the most what?
Oftentimes the most difficult is getting the, getting through that initial, blunt, getting hit over the head with a 2x4 of how bad it is, because it's difficult to tell people how bad news, and so I'd say the more difficult time is when people have come and seen an oncologist or two already and had no idea like how bad it really is, and so you're kind of hitting them over the head with that at your first meeting, and nobody's been kind of brave enough to step up to the plate and kind of say that to them in the past. Yeah, I can understand, because that is maybe it's draining on you to do that, and perhaps if you're not an expert in the field, you might not feel comfortable saying something if you're not really entirely sure about it either. So, but we do get a fair amount of people who come in who just have no idea how bad it is,
How
or
serious it is.
in some cases if it's not curable, that's that's even in some cases where that's kind of obvious by the way that it looks, or how advanced it is, and so that part can be pretty tough if people are not well prepared for that. It's sort of like hit and miss. I mean, some people are like you, pretty well prepared for that, and some people not. And so in your case, it's more about the expectation management than afterwards, and kind of wanting to motivate somebody to keep trying and fighting it and giving it the best shot, but without.
We lost Dr. Brohl's audio for a minute during the interview, but what he was saying was giving people hope, but also giving them realistic chances and odds for survival and outcomes is really important. So what are some of the things, besides the reality of their situation, that you wish patients knew when they came in that would help them have a better working relationship with you as a provider?
Well, I think I appreciate when people come in with some degree of ownership about their care, and taking some initiative on their own to sort of try to figure out on their own at least to some degree, what they're dealing with and what's been found so far. This certainly applied to you, coming in and wanting to know all the details, and kind of knowing all of your radiology results and so forth, and pathology, what you've been told so far, and asking for extensive detail, I think, from your previous doctors, as much as they would give you. But some people come in and don't really, are kind of a little bit clueless about what's even been found. Where there's multiple tumors, not just one. What's seen on my radiology? What is this even being called? Some people are just told what, and I don't know if it's the fault of the patient or the people who've seen them before that get them to us. Some people will come in kind of clueless, just like, hey, go to Moffitt, go to the referral center, and kind of they'll tell you all you need to know. And so I kind of like it a little better when people are a little bit more prepared, and sort of ready to have a more working relationship with me, and sort of have more of an understanding and some thoughts on their own about what kind of the options might be that we're talking about, and having some questions prepared, about what to ask. So I kind of like a little bit of preparedness. There's probably a degree where it gets too much, a little bit too much of like the, Google MD, researching everything, which of course, every doctor complains about, and, a little knowledge is a dangerous sort of thing, but to some degree, at least being aware of the main details of, kind of like their case and what's been found, and some of the, more at least mainstream expectations and so forth, I think is pretty helpful, and so that people have been thoughtful about it, and also kind of know what they might be in for, and what they might be willing to do or not do. I mean, there's some people that start talking about chemotherapy, for example, they didn't really consider the possibility. They just kind of like ignored that could be a possibility, and haven't thought about whether that's something they would want to consider or not. So that's sort of the degree of things I wish people would come in with when I first meet them.
Well, because I think of you as you guys at Moffitt are like okay, what are my options and what should we do now, guys, people? Whereas the other people are well, what the heck is going on? I just, like when I met with my cardiologist, my cardiothoracic surgeon, my original oncologist, they helped lay out the picture about what was going on, what the tumor looked like, how the resection went, that we had one area that didn't have clear margins. Then when I met with Anna, it was, what are the expectations? Here's how sarcoma normally behaves, blah. So that when I got to you guys, it was like, okay, I know all this stuff about what's going on. What do I do now? What are my options? I feel like to go to a research center without any understanding of your case is you're doing yourself a disservice.
Yeah, I mean, I think that's a great way to put it. The what's going on questions, the quicker you can get past that, and into the, what are the options, I think the better, your time is spent with us, and, and the better I can sort of talk about that sort of a level, that layer. So yeah, I think getting past that initial layer is definitely ideal or better, for the initial meeting when I'm seeing people in my clinic.
So, anything else on that question? Anything else you wish people knew before they got into that room?
I think that pretty well covers it. I mean, we spoke about, to some degree, expectations as well, and having a little bit of at least a ballpark sense of the expectations is helpful. I don't need people to come in, knowing that their odds are 5.2% or something like that. But I do want people to know whether we're talking about something that is probably curable or probably not, or definitely not curable, or just some really kind of ballpark expectations. I think are pretty helpful, and often are provided, but not always. And so, again, it's just hard to have a conversation that's a working conversation about what are the options until you get over some of these initial shocks. It's just like the stages of grief almost. It's hard to get past denial. You have to, and so. Getting some of those initial things out of the way, let's say, to get to this. All right. What are we actually going to do now? What are the options, and how are we going to do this? It's helpful to be able to get to that point if you've already had some of these initial, let's say, things out of the way. Just like you said, the overview and the expectations to some degree.
That makes sense. And then we had some audio issues, so I'm not sure if this is repetitive, but. When I asked Dr. Brohl, and he said, I asked him if this was worth even doing the chemo and the radiation, because if this was just going to kill me anyway, why would I want to go through that for the last few months of my life? And he said that there was this really small window, really small chance of a really great payoff. And that it was, it was up to us if we wanted to do it, but that chance was there. And so we decided to take that chance and to do this this very aggressive radiation and pretty aggressive chemo as well for that chance, which 5% or whatever it was, 5.2. Thank you for the decimal point now. It was not a hard decision to make, but it was a hard decision. And I'm trying to figure out what the distinction between those two statements is. For me, because I love Kev, because I want to be around more, because I love my kids and I want to be here longer, that was an easy decision to make. It's like, we'll take this shot. And it may very well kill me. I don't, it may, but I felt like I had to take that shot. But we still had to have all those conversations, and we had them primarily where both our kids were at camp one week, and we were driving back and forth to radiation every day, and it's about an hour and a half each way for us if there isn't traffic. Mm-hmm. Talking about, okay, and I'll start crying. So if I don't make it, then what? And we had a friend who does end of life planning come while the kids were at camp again, and mm-hmm. just kind of go through stuff with us. And he said, we're just making a plan. We're not setting a date. And so we just kind of planned out what we wanted and what we didn't want. And Kev did it as well at the same time. And um, those were really horrible conversations to have, but they were necessary to kind of get through some of the logistical and procedural stuff and then move on to the other stuff we wanted to do. And I think it's kind of the same way when you get a diagnosis. You have to do hear those hard things and have those hard conversations and make those hard choices.
Mm-hmm.
And then you just move forward and do it. And you hope and you pray that it works, but you've got the other stuff taken care of to the point where that's not constantly on your mind. And we were very frank with the kids too. They didn't know every detail of every treatment.
Yeah.
But they knew that there was a chance I wouldn't make it. And the way Kev said it to them was, Mom will probably, they're pretty confident she would be here till, I think he said Thanksgiving or Christmas. That's what they told us. After that, we just don't know, but this is what we're going to try. And we explained about the kind of the moonshot approach to this. And that was horrible. That conversation was the worst one out of all of them.
I'm sure.
Yeah, but it was important.
In one of our original meetings, when we were discussing chemotherapy and what, just sort of the overall plan of attack, I remember we had a conversation about how are you going to phrase it to your kids.
Yeah.
And I think I was trying to give you some advice, even though I have no idea what it's like to be in that exact situation. But I, try how to phrase it about, you did. It's sort of like how you guys laid it out or how you said it just there. How it's unfortunately it's an aggressive cancer type that historically doesn't have a high success rate, and we're going to treat it aggressively to try to give it our best chance. And we're just going to take it a month at a time, but we know that it could go badly. We know it could go badly soon, within 6 months or something, and so I think, setting sort of realistic expectations, but still maintaining some, window of hope is the way I try to do it, just like I try to give to you, and, try to encourage you to phrase it like that to your kids as well. And so you sort of have the same experience that I have, in my day-to-day, sort of turning that back around to give that same sort of balance to your children when you're trying to describe it to them. So, I guess hopefully just having, heard that or, modeling it sort of after how I talked to you about it, hopefully that was helpful, I guess.
Oh, it was super helpful because I didn't want to tell them anything that wasn't true.
Yeah.
That was the main thing. It's like I wanted, as awful as it was, I wanted them to have an honest expectation and a realistic expectation of what could happen. So
yeah, and I think I told you at the time that this is it's not unrealistic to tell them that there's a small hope, and that that's and that you should tell them just the way that I'm telling you that it is, the odds are against you, and it is a bad cancer, and many people don't survive this cancer, but there is a small hope, and we're going to try our best for that hope. And that's, I don't think that is a lie to your children to tell them that, and because I'm not lying to you about how I'm telling you that right now. So that's, I think what I said, something like that to you. I'm probably paraphrasing myself a little bit, but that's
no, but it was very similar to that, and it was it was straightforward, and it was what you told me, and it was what we told them, and as things went along, them having that in their back pocket, knowing this may totally not work, but there's a chance. And so we're going to hope and pray for that chance and work as hard as we can to get that.
Yeah. And I think, the more, upfront and blunt you could be with someone, the more that they can trust you when you do tell them that there is a small window of hope. And the way that you phrase that is very important. And for me, or for the way that you're telling your children the same way. And that's what I'm trying to strive for when I talk to people about it. And I think, in general, I come across as pretty blunt because I tend to lead with the bad news and sort of be pretty upfront about that. And so I think when I do talk about the more hopeful side of things, I think it's at least more believable, and, probably the same way when you tell your children that too.
Yeah. That's one thing I like about you is you don't sugarcoat anything. but you're also not depressing. And I don't know how you manage to pull that off, but good on you because that works. It's working for
Yeah,
you.
yeah. I don't know. I'm not sure, but thank you for that compliment. But that's I find that bluntness works the best. People just really want to know the truth and don't want things to be sugar coated in this field. I mean, so I can't tell you how many times people have thanked me for telling them that they have an incurable cancer that I can do nothing for.
Wow.
People just thank you so much for telling them that so upfront. And when I tell them, really, you shouldn't go through chemotherapy. I think it's just going to, pile on, and it's not going to help you that much. And I really don't think it's for you. I don't think that we should do that. I can't tell you that's almost never been met with no, or like that's, you're a fraud. You don't know what you're doing. That's almost always met with thank you so much for just telling me that. So I don't know. I think that's by far and away the best way to go is just sort of really, really bluntness. And I don't know. I guess I'm an optimist by nature. I guess that's part of the reason I went into oncology, because you have to sort of maintain some optimism, I guess, to be in this field and do it, and try to find the cases like yours that have gone real well so far. And that's you keep motivating you, I guess.
Well, and I think it takes a special kind of person to be able to do that and be resilient, I think, delivering that kind of bad news and still maintain optimism. And I'll tell you, I've told people this for years, I can deal with anything if I know what it is. I may not like it, but I'll figure out a way to deal with it. But if people, kind of hedge or lie or whatever, and you don't know the truth of what's going on, how do you know what you're dealing with, and how do you make a plan to move forward?
Yeah, and that's a particularly difficult problem in my field of sarcoma. And the one you deal with is that it is a field, because of the rarity that comes with a certain degree of uncertainty. And so people really have a difficult time dealing with the uncertainty of it, and even the uncertainty of sort of the medical recommendations, whether or not to give chemotherapy or not for a case like yours is, probably most people would, but even that is somewhat of a matter of debate. There's some, even experts that would say, that it's probably not going to move the needle that much, and some that would say you definitely have to try because it might help a little bit. And so, even within our field, because it's so rare, it's hard to have definitive answers like you do in some of the other cancer types where you test all these different permutations and, are able to do more, clinical testing and experience from it. And so there's this uncertainty factor also. And also sometimes the diagnosis is hard to come up with. Like in your case, we still kind of go back and forth between these two different diagnoses sometimes. And some people are like, what the heck, you can't even tell me what I have, and you're like this expert center. What's going on here? Like, maybe I should go somewhere else. So, there's this extra uncertainty factor that makes it, I think, particularly challenging for these rare cancers that make it even more difficult, where there's not, we treated 1,000 people this way and 1,000 people the other way, and we know for sure that this way is 2% better. This is, we just don't have that for a lot of the things we're dealing with. And so we have to talk in uncertainty sometimes and hedge a little bit sometimes. And when we're talking to people about our recommendations and that's a real challenge, I think, for a lot of people and for the doctors too, frankly, to try to deal with that degree of uncertainty.
Well, and I think I'm okay with it being your best guess.
Yeah.
And that's what you have to kind of come to, especially with the rarer ones. And I always say things like, if it was your sister, if it was your wife, if it was your mom, and you liked these people, what would you do? And I'm okay with knowing that's your best guess for someone you care about, someone you love. This is what you would recommend given the same circumstances. And it's a guess. And that's okay.
Yeah, no, and I think that's sometimes how I phrase it, is that, I've learned over the years to phrase it like, hey, it's not definitive because it's rare. And, you could go to 3 different sarcoma experts around the country, and one of them could tell you no chemotherapy, one could tell you definitely chemotherapy, and one could be like me. It's like, I think probably chemotherapy. Like I tend to be a little bit more in between, I guess, or more flexible than some that are a little more dogmatic. But that there is, that definitely happens in this field, and you do have to kind of phrase it as your best guess sometimes, from your experience, and be again, blunt about that to some degree. And I think, as long as you can, if you're comfortable with living in that uncertainty, I think the patient you're talking to gets more comfortable living in that uncertainty.
Yeah.
And so that's, you have to sort of, embrace that to some degree, I think to be most effective. And so, yeah, that's one thing. And I don't know, I mean, I agree with you. It is a challenge and it is draining. And, that's part of the reason I do research and part of the reason I split my time, to be quite honest with you. I think it would be challenging to do this job every day for, seeing patients 5 days a week and delivering this news 5 days a week and maintaining that optimism and that and the energy for that. It is a more draining day when I see patients that day than, I come home ready for like a recharge, when I'm spending the day in the lab, the following day or the day before, it's a little different drain on your psyche, a little different, amount that it pulls from you. And, I enjoy that, but it also is draining, and it's sort of one of these things that like you want enough of that you can take, but not too much.
Yeah.
And just, so I guess thankfully I've been able to carve out the amount that's right for me. But I do think a lot of people go into oncology because they to some degree want to deal with that level of difficulty on an emotional level. And, want to feel like they're dealing with something important and challenging. And, want to get moved to a certain degree of emotions. It's the same reason people want to go to see a sad movie or want to go to, I don't know that just people find it, it's important to do these things. And I think that, a lot of us are, appreciate that aspect of the job. I certainly do, and it's a really rewarding part of it.
Well, you're definitely doing work that matters. It matters hugely to me.
Yeah.
Yeah, I'm not going to do it while you're here, but I do sing your praises. You and Dr. Nagavi, particularly, just the two of you and the way you guys work together and the difference it has literally made in my life. So thank you.
You're very welcome.
Okay. You've made me cry. Okay. So now a couple of...
Too difficult to do, I don't think.
What'd you say?
I'm not sure that was too difficult to do to make you cry. I'm not sure.
Okay. Hey, it's true. Let's not get it all out there. It's totally true, though. I kind of wear my heart on my sleeve. So
I love it.
Couple more quick questions. Number one, so your life's work, what has it taught you about people or about life in general? Like if you had to sum it up in a couple of little quick sound bites.
Gosh, I mean, one thing you learn very quickly is that life is just so fragile. Health is so fragile. Anybody that's going through anything like you have, finds it out right away. And I certainly see that secondhand. It's something we take for granted so easily, and it just can go so quickly. And that's obviously the number one in your face lesson, I think. But I think that it does make you feel like there is a meaning to life, and a meaning, people, their lives and their time are just so meaningful, and it gets in some ways exaggerated when they're faced with their mortality. I'm sure that's something that you've experienced, and it's something that's hammered home every single time you see somebody dealing with a difficult disease like cancer, or like a sarcoma, especially. And so that's, I think that's my little soundbite lesson. It's life is meaningful and it's worth fighting for, and but also it's fragile and it's temporary.
Those are really good sound bites, by the way. Okay. So first of all, thank you. Second of all, a couple of things about you. Like, do you have a couple of things on your bucket list items that you'd be willing to share? Like places you want to go, things you want to do besides curing cancer. We know that, but anyway.
Man, curing cancer's got to be number one on my list, but I'm still working on that. But no, I mean, I'm mostly, focused on work. I'm focused on family. I have a couple of small boys, and my most important things are just are those two things. Seeing my family grow and prosper, and trying to guide them to grow up well and carry on, I guess. And I do travel a bit, and so I've been able to do a lot of bucket lists. Thankfully, I'm very blessed in that way. So I don't have like one necessarily specific one. It's just these more general things.
No, those are good though. And then that probably wraps into the last thing I was going to ask you. What's your favorite place, or what are your favorite places to be, if you had to pick one or two?
Well, I think one of my place that's near and dear to me is Dubrovnik, Croatia. This is where my wife is from, and we got married there.
Oh, cool.
And so we do travel back there almost every summer, though it's been a little pushed back with the pandemic. We are going to try to go later this summer, and let the boys see their heritage, I guess. And it's a beautiful place that it's like a tour, a cruise ship stop there with tourists and stuff like that. So it's a real nice area, and that's that place is real special to me now through by marriage, I guess.
It's so funny because Kev and I were looking at Croatia, because it's not in the Schengen countries, so you can live in Croatia longer than you can in like Italy.
Mm-hmm.
So we actually were looking at that and some houses there and thought, man, that would be really nice. It's lovely.
It's a beautiful place. I'd highly recommend it.
Very cool. Well, first of all, I want to thank you for your time today and for putting up with the audio issues.
No problem. It's my pleasure to be here.
Well, and secondly, I want to thank you for me. So just thanks. And yes, it's not hard to make me cry, but without you guys and your help, I don't think I would be here today. And, I know things can always get bad again, blah, 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 whatever, but I'm living a pretty good life and I've been healthy, and that's pretty amazing to me. So thank you for that.
No, you're so welcome. And it's just so great. We love this, and we love how well you're doing, and so happy that I didn't overpromise and underdeliver. I think we
oh my gosh,
thankfully went the other route and underpromised and over. I don't know. It's much better to be in that way, I guess. So,
absolutely.
It's great being here talking with you, and it's great being here talking with you.
As you can tell by our conversation, Dr. Brohl is just good people. He's dedicated to his work, he's dedicated to his patients, and he's just an all-around great guy. He's also an example of the kind of people they have working at Moffitt Cancer Center, and I would highly recommend it if you ever need a specialist who can help you with something that maybe your regular oncologist can't. This week, as you go around the world, please count your blessings, look for the good in others and in yourself, do something nice for somebody else that makes their day a little easier, and make it a great week. Thanks for listening.